Hello and welcome to Pediatric Simplified. In today's video, we are going to discuss about management of febrile seizure, how to diagnose febrile seizure, how to treat febrile seizure, what is the prognosis of febrile seizure, and how to prevent febrile seizure. Let's get started. History and physical examination are important when it comes to diagnosing and treating febrile seizure. And to rule out differential diagnosis. In seizure, you should ask what is the type of seizure, what is the duration of seizure, post-ictal state, and what is the frequency, and accordingly you can classify it as simple or complex febrile seizure. Then in fever, you need to ask about duration and frequency and temperature. Okay. In associated symptoms, what are, if there is any cough, cold, loose motion, vomiting, pain abdomen, burning micturition, ear discharge is there. In meningitis symptoms, ask about any photophobia, neck stiffness, headache, or altered sensorium. These are the symptoms of meningitis. Then ask about symptoms of raised ICT, like headache and vomiting, confusion, irritability, etc. So these meningitis and raised ICT symptoms must be asked. Then neurological or developmental symptoms. So whether any neurological abnormality is there, whether any developmental delay is there, whether child was given any trauma or toxin. Then coming to family history, whether in family there is any history of febrile seizure or epilepsy. In immunization, two immunization are important. One is Hib immunization and one is pneumococcal. Because these two will cause meningitis. Then in physical examination in GCS, just find out the GCS and monitor it. Vitals, check any instability in vital, low BP, etc. and treat that. Head to toe examination, you should be looking for any signs of pharyngitis or any rashes or any ear discharge. So you have to look all of this. In meningitis, what are the signs of meningitis? Neck stiffness, Kernick-Side and Brudzinski sign. So look for that. In raised ICT, look for any instable vital or any squint, apparent squint, or increased ICT. In a squint, you should look for pupillary reflex, whether any sluggish pupillary reflex is there, you should look for that. Right. Then if anterofontanel is open in a small child, look for anterofontanel. If it is bulged, non-pulsatile, etc. Then developmental assessment should be done and neurological examination should be done. Next comes to investigation, blood investigation, CSF, EEG, CSF analysis, EEG or electroencephalogram, neuroimaging like CT or MRI and other investigation, and genetics. Genetics is very rare, we'll do genetic testing. And first of all, you need to remember first episode of simple febrile seizure, then there is no need for any investigations. It is important. If it is simple febrile seizure, first episode, you need not do any of this. If it is a complex febrile seizure or any other abnormality is there, then you should do investigations. Then when to do investigation and when not to. If it is a simple febrile seizure, Okay, or simple febrile seizure, single or multiple, whatever, no investigation needed. If it is a complex febrile seizure, then you may do investigations. It need investigation like EEG, MRI, or CT, or blood investigations, etc. If you are suspecting meningitis means what? If the child is sick looking, or if the child has symptoms of meningitis, like we discussed previously, okay, then you should do CSF analysis. So that is when to do investigation and when not to. If simple febrile seizure, no investigation needed. Complex, you can do EEG, MRI, CT, blood, and if you are suspecting meningitis, do CSF analysis. Then investigation for febrile seizure, blood investigation. In blood investigation, blood glucose, we call it GRBS. We do it in all pediatric seizure cases. Electrolyte and ABG, it is not mandatorily required if child has dehydration or child has uh, repeated diarrhea or vomiting, persistently diarrhea, vomiting, then you should do electrolyte and ABG. In electrolyte, you can do sodium, potassium, calcium, magnesium, etc. Sodium level, if low during presentation, then recurrence of febrile seizure is high in future. So that will give a clue in the serum electrolyte. Other investigation you can do in blood investigation, you can do CBC, blood culture sensitivity, or any other investigation based on the etiology what you are suspecting. And serum ferritin, if you do, if it is less than 30 microgram per liter, then recurrence risk is high. So you need to give iron supplement to those patients who are deficient in iron. Then CSF analysis to rule out meningitis. So in CSF analysis, usually it is done to rule out meningitis. So when you do lumbar puncture, there are indication of CSF analysis. One is absolute indication. It is when you must do lumbar puncture. One is relative indication, when you have option to do lumbar puncture. Absolute indication is when child is less than 6 months old, or child has symptoms of meningitis, child is sick looking. If less than 6 months old, so the diagnosis may be meningitis, most likely it is meningitis, so you must do LP. If symptoms of meningitis are there or child is sick looking, so you have to do LP at any age. The child is of any age, you have to do LP. Options for do LP. If the child age is 6 to 12 month old and immunization status is not known, or 6 to 12 month old and Hib and pneumococcal is not given, okay, or the child is previously treated with antibiotic, then to rule out partially treated bacterial meningitis. Okay. So then you have to do LP. Febrile status, you have an option to do LP. Okay. So CSF analysis, some are absolute indication, some are optional indication. Absolute is less than 6 months and symptoms of meningitis are sick looking, you have to do LP. Then next comes EEG. So EEG, what are the indication for doing EEGs? These are the indication. If it is complex febrile seizure, then you should do EEG. If high risk of epilepsy is there. So EEG, when you have to do EEG? If it is a complex febrile seizure, then you have to do EEG to know the type of seizure. Okay. Remember, if it is a simple febrile seizure, first episode. Then no need EEG. EEG is not required if simple febrile seizure and first episode. If complex febrile seizure, to know the type of seizure, do EEG. If high risk of epilepsy is there, so that is also to know seizure type so that you can treat accordingly. If it is febrile status, if you do EEG and there is focal temporal epilepsy, focal temporal slowing of EEG, then there is chances of developing into temporal lobe epilepsy. Risk will be there, risk will be high. Then neurodevelopmental anomaly, so you have to do EEG to differentiate between non-convulsive status and post-ictal state. Suppose a child not improving, child came with seizure and child is not improving, then child might be having seizure or child is in post-ictal stage. You don't know that. To rule out that, to differentiate, you have to do EEG. So EEG always should be done uh, so EEG should be done after 2 weeks. After 2 weeks, you wait for 2 weeks, then only you should do EEG, and the EEG should be done for at least 20 minutes. And both sleep EEG and awake EEG should be done. One exception is febrile status. If you think it is febrile status, then it is an emergency condition. You cannot wait for 2 weeks. You have to do within 48 to 72 hours. EEG should be done within this time. Okay. So then neuroimaging. One important thing here is EEG will not predict future febrile seizure or future epilepsy. Remember that EEG will only predict, it will not predict future febrile seizure or future epilepsy, as it is general belief that it will tell you about future epilepsy. It will not tell, it will tell about the type of seizure or type of seizure child has, so that you can treat accordingly. Neuroimaging. So what are the indication? If it is complex febrile seizure, you do neuroimaging to know the, to see the pathology. So where is the problem? If it is febrile status, then you do neuroimaging if to see hippocampal edema. So if there is hippocampal edema is there, the chances that in future child will develop temporal lobe epilepsy will be more. Generally it is same, if a child has hippocampal edema, future it will develop temporal lobe epilepsy. If head is large, to rule out hydrocephalus. Okay. Hydrocephalus might be there if head is large. Then you have to do neuroimaging. If raised ICT, then there must be a cause. To find out the cause, if it is tumor or what intracranial space occupied lesion is there or any other pathology, meningitis, you have to find that through neuroimaging. Neurological deficit or abnormality is there, so you must do neuroimaging. So these are the indication. If head is large or raised ICT features are there, or child has complex febrile seizure, febrile status, neurological deficit, then do neuroimaging. In neuroimaging, you have an option to do CT or MRI, etc. Then in others investigation, to find out the cause, which system is involved. As per that, you can do whatever investigation you like, X-ray, urine test, ultrasound, whatever you feel like you can do based on the underlying cause you are suspecting. Genetic test, genetic test is not very helpful. It is done rarely, I told you previously also. But SCN1A is one gene that if you are suspecting Dravet syndrome. Dravet syndrome we have discussed, one of the most severe form of febrile seizure induced epilepsy syndrome. So Dravet syndrome is a very severe condition. SCN1A gene mutation is associated with 80% cases of Dravet syndrome. So genetics test will rule out that. Otherwise, it is other epilepsy syndrome also genetic test will rule out. Right. Next is treatment of febrile seizure. In treatment of febrile seizure, first is ABC, airway, breathing and circulation. Keep the child in lateral position. Lateral position will prevent the tongue to fall back. Okay. So tongue fall back, it will prevent that. Then whatever secretion, it will rule out. If you keep the child in lateral position, then suction, saliva or any secretion you should suction out. Then give oxygen, and BP you check to rule out low BP, hypotension. So you have to treat low BP condition. Then antiepileptic. Next treatment is antiepileptic. In antiepileptic, first you can give lorazepam, midazolam, diazepam, etc. These three antiepileptic usually we give. Lorazepam, what is the dose of lorazepam? So lorazepam dose is 0.1 mg per kg per dose. Okay, IV or IM. If you are giving IV, to give over 2 to 5 minutes. Slow. Okay. Then next is midazolam. If you are giving midazolam, then the dose is same 0.1 mg per kg per dose. IV or IM over 2 to 5 minutes. Slow you should give. Then intranasal spray. Intranasal spray of midazolam. So this is usually the dose is 0.2 to 0.3 mg per kg per dose, divided between two nostrils. Okay. So intranasal spray, it is very important. So parents can keep it handy at home and use. Diazepam. Diazepam can be given IV or can be given per rectal. The IV dose is 0.2 to 0.5 mg per kg per dose. Per rectal dose is 0.3 to 0.5 mg per kg per dose. So diazepam should be given always slow. It should be given slow. The difference between lorazepam and diazepam is lorazepam is longer acting. And lorazepam has less side effect. Side effect as in, what are the side effects that diazepam can cause? That is respiratory depression and hypotension. Right. Then comes to phenytoin. So diazepam, if given rapidly, it can cause respiratory depression and hypotension, and this side effect are less with lorazepam and midazolam. So they are preferred. When it comes to phenytoin, if the seizure is not coming down, you can give this diazepam, lorazepam, and midazolam uh, for after 5 to 10 minutes. You can repeat if seizure is not coming down. Okay, in phenytoin, if seizure is still not coming down, you can give phenytoin. The dose is 15 to 20 mg per kg per dose. Dilute with 50 ml NS and give over 30 minutes. It should be always given over infusion. Okay, phenytoin, instead of phenytoin, you can give fosphenytoin also. Right. Fosphenytoin, same dose. This is phenytoin equivalent. Phenytoin equivalent dose is 15 to 20 mg per kg per dose. Next is antipyretic. Antipyretic, first is paracetamol can be given. It is the paracetamol is the most preferred antipyretic. It can be given as suppository. When child comes with febrile seizure, you give paracetamol suppository. Later on, when the child is conscious, you change it to oral. The dose of both suppository and oral is same, that is 15 mg per kg per dose. Then you make it 4 to 6 hourly, same dose you can give. Maximum paracetamol is 60 mg per kg per day. Don't give more than that. Tapered sponging. In tapered sponging, so you do tapered sponging, that will reduce the fever. As soon as a child comes, so you can ask one assistant to do tapered sponging for the child also, if you have help. Then treatment of other causes. Other causes should be found out and should be treated. For example, if it is otitis media, then give antibiotic. If it is URTI, give symptomatic treatment of URTI, etc. Then comes to febrile seizure do's and don'ts. So what parents should do? Suppose for parents, if they find out child is developing febrile seizure at home, what they should do and what they should not do. They should take the child to a safe place. Means if there is any fire nearby or child is near a swimming pool, then take the child to a safe area. Keep the child in lateral position to prevent tongue fallback. Then remove any tight clothings of the child. Then watch time. So often parent miss this thing. You have to start looking for the time. What time is it? Tapered sponging and paracetamol suppository. If you know how to give paracetamol suppository, you can give, or else give only tapered sponging. Then midazolam nasal spray, if you have, then your doctor will tell you the dose. Based on that, you can give. If the seizure persists for more than 5 minutes, okay, more than 5 minutes, or child is turning blue, the mouth and lips are turning blue, it is less than 5 minutes, but child is turning blue, then you have to call for emergency or ambulance. Usually febrile seizure lasts 2 to 5 minutes. It will remit on its own. Okay. You have to just keep the child lateral position, do sponging, and it will remit on its own. Don'ts of febrile seizure: do not restrain the child forcefully. That is first thing. Do not put anything inside mouth. Do not give any food or medication orally. That will cause aspiration. So don't do that. So do not put the child inside water to cool the child. So this also you should not do. Next comes prognosis of febrile seizure. Parents often ask, what is the prognosis of my child? Okay, then you need to first assure them that febrile seizure is a benign condition. It is a harmless condition. Then parents will ask whether there is any long-term effect on brain of my child. So there is no long-term brain damaging effect of febrile seizure on a child's brain. And another thing that bothers them is whether it will impact my child's school performance. Then you need to tell them it will not hamper child's learning on attention or cognition or scholastic performance, will be normal for the child. Whether it will recur or not in the future. Febrile seizure may recur in the future. So you can calculate the risk of febrile seizure, how much recurrence will be there. We'll discuss it later in another slide. So febrile seizure, you tell them yes, febrile seizure may recur in future. If it is complex febrile seizure, chances of recurrence is more. But if febrile seizure recurs in future also, there is no problem. What are the chances that febrile seizure of my child will develop into epilepsy in future? Yes, febrile seizure may develop into epilepsy in future. And what are the chances? It is more if it is a complex febrile seizure. So if it is a simple febrile seizure, it is a 1% risk of epilepsy. If it is a complex febrile seizure, then risk of epilepsy becomes 6 to 29%. The risk of epilepsy is high if it is a complex febrile seizure. Okay. There are other risk factors also, we'll discuss subsequently. Here is a risk of febrile seizure recurrence in future. Here is risk of febrile seizure recurrence in future. So what is the major risk factor and what are the minor risk factor? If age of the child is less than 1 year, it is a major risk factor. If duration of fever is less, within 24 hours of fever, child had seizure, then chances of febrile seizure recurrence is more in future. If temperature is between 38 to 39 degrees Celsius, that is between 100.4 to 102.2 degree Fahrenheit, that is low temperature. If at low temperature, a child is developing febrile seizure, means more chances are there that in future child will have recurrence. Minor risk factor, if family history of febrile seizure is there, if family history of epilepsy is there, if child has complex febrile seizure, then it is a minor risk factor for recurrence. If child is a male gender in daycare, or child has sodium at presentation. Then comes to minor risk factor. If family history of febrile seizure is there, if family history of epilepsy is there, a complex febrile seizure is also a minor risk for febrile seizure recurrence. If a male child going to daycare, then risk of recurrence will be more. Low serum sodium, we have discussed it previously. If during presentation child serum sodium is low, then chances of recurrence is more. So how to calculate that? If one risk factor, recurrence is 25 to 50%. If two risk factor, recurrence rate is 50 to 59%. If 3 risk factors, then recurrence rate is 73 to 100%. Almost 100% recurrence if 3 risk factors are present. So here is another thing I want to mention specially. If age of the child less than 1 year, then recurrence rate is 50%. If more than 1 year, then recurrence rate is 30%. Similarly, if one episode of febrile seizure, recurrence rate is 30%. Okay. If after second episode of febrile seizure, recurrent rate will be 50%. Okay, important thing. Age less than 1 year 50%, more than 1 year 30, and one episode is 30% and 2 episode is 50% risk of febrile seizure. Then risk of future epilepsy. If what are the risks that my child will develop into epilepsy in future? So if it is a simple febrile seizure, it is one episode of simple febrile seizure. Risk of recurrence is just 1%. If it is recurrent simple febrile seizure, risk of recurrence is little more, 4%. If it is complex febrile seizure because of duration more than 15 minutes or more than one episode in 24 hours, then risk of recurrence will be like 6%. If it is a complex febrile seizure because it is a focal seizure, then risk of recurrence 29% of recurrence into epilepsy is 29%. If fever is less than 1 hour before febrile seizure, then epilepsy risk is 11%. If family history of epilepsy there, then epilepsy risk is 18%, and most highest is the neurological abnormality. If it is there, then epilepsy risk is 33%. So the percentage of developing into future epilepsy is between 1 to 33%, and it varies from one child to another child. If neurological abnormality, highest recurrence risk. Simple febrile seizure, very minimal epilepsy risk. If complex febrile seizure, more epilepsy risk. Even if it's focal and complex febrile seizure, even 29% risk. Let's come to prevention and prophylaxis of febrile seizure, which can be done with antiepileptics. So in there are two kinds of prophylaxis. One is intermittent prophylaxis and another is continuous prophylaxis. Intermittent prophylaxis is given whenever the child has fever. Most commonly used intermittent prophylaxis is clobazam. The brand name of it is Frisium. So clobazam is given as oral tablets. The dose is 0.7 to 1 mg per kg per day in 2 to 3 divided doses. Okay, over 3 days. During fever, suppose fever lasts for 10 days, clobazam is still given for 3 days. Other antiepileptic like oral clonazepam and diazepam can also be used as a prophylaxis, but these are not that common. Commonly used is clobazam. Then continuous prophylaxis is very rare. So it is given in certain special conditions. When the risk of epilepsy is high, then give continuous prophylaxis. If child comes with febrile status, then you can give continuous prophylaxis. If intermittent prophylaxis is not working, suppose you are giving the child antiepileptic prophylaxis when child has fever, but it is not working. That means more than 3 episodes of seizure in over 6 months, or more than 4 episodes over 1 year. then you will call it intermittent prophylaxis not working. In that case, you can give continuous prophylaxis. Now, few medication for continuous prophylaxis are valparin or valproic acid, then levetiracetam, and phenobarbital. So continuous prophylaxis means it should be given every day. And till when it should be continued, there is no such guideline. Usually it is given 2 to 3 years in practical scenarios. But one thing you need to remember, that prophylaxis, drug prophylaxis is not needed in case of simple febrile seizure. Okay, in simple febrile seizure first episode or in simple febrile seizure, even in recurrent episode, there is no need for any drug prophylaxis. Nowadays, this intermittent prophylaxis is not recommended these days. If it is not simple febrile seizure or something else, then you can give prophylaxis. So this you remember. So antiepileptic prophylaxis, it is not needed in simple febrile seizure first episode or recurrent episode. Okay. Then another thing is, there is a common belief that paracetamol can reduce the recurrence of febrile seizure, which is not true. If you give paracetamol for further fever, then it will reduce the discomfort of the child in subsequent episode of fever. Later, if the child develops fever, if you are giving paracetamol, it will reduce the discomfort. So here I am not talking about the current episode of illness, in the later episode. So it will only reduce discomfort. Iron deficiency, there are studies that show that if a child is iron deficient and is given iron prophylaxis, iron treatment for iron deficiency anemia, then it helps to reduce the recurrence of febrile seizure also. So that is important. Need to treat iron deficiency anemia. Okay, that is for all today. Thank you for watching today's video. There is another video, part 1 of febrile seizure, where I have discussed what is febrile seizure, why is it more common in children, what are the types, causes and symptoms of febrile seizure. Do watch that video too, and if you like my videos, then subscribe to my channel. Thank you.